challenge to dignity. Our goal was to link academics, activists, and agencies concerned with the health of refugees and asylum seekers in a spirit of collaboration and comparison, bringing together professionals working with different populations of forcibly displaced peoples, ethnic groups, and nations. The video you are watching will contain an individual presentation edited to stand alone. We hope you find them to be of value. Welcome back. Our first speaker of the afternoon is Dr. Peter Ventevogel, who is a psychiatrist and medical anthropologist and is the senior mental health expert with UNHCR. He's coming to us from, I believe, from Switzerland. And his topic is, does humanitarian mental health care amount to epistemic violence, or is it a matter of saving lives and addressing social injustice? So to address this question, Dr. Peter Ventevogel.
Okay, I'm now sharing my screen. Is that also the case for you?
We can see it, but it's not on slideshow view. There it goes. Okay.
Okay, great. Okay, thank you very much for the invitation. And it's sad that I couldn't be with you in person, but well, it actually feels a little bit like I am with you, like having followed the excellent presentations of the colleagues yesterday and today. So I hope it will bring us together somehow. What I want to do is to take you a little bit into my world, which is the world of what I would say humanitarian mental health care. So mental health care in post-conflict settings and emergency situations. I do this work for 20 years now. I'm trained as a psychiatrist, which is a skill that is very helpful in the kind of work that I do. But I'm also trained in social sciences, in medical anthropology, and that's also very helpful. Although sometimes I feel, go to say that I feel there are two souls dwelling in my breast. It's not so easy to combine the two perspectives. And I am passionate about what I do in global mental health, but I also feel we sometimes need to critically reflect on it. And I hope that this meeting creates a safe space to do that. So my first disclaimer then is that you see on the slide that I work with UNHCR, the United Nations High Commissioner for Refugees, but I don't speak on behalf of them now, which is important because I can speak a bit more free. Not that I think there will be major disagreements, but in the end, I am a civil servant. So this is all on personal title. Well, the first thing I want to say is that within humanitarian mental health, we actually use a broader concept. We talk about MHPSS, a horrible acronym, but it stands for both the more health-oriented interventions, clinical psychology, as well as community-oriented social interventions, mental health and psychosocial support. That is a field that has been growing in humanitarian work over the last decades. And there is good reason for that, because the needs are high and the resources locally are very low. They're either shattered by the emergency itself, or even when they're still there, they're not able to cope, which is the very definition of a humanitarian emergency, a situation where the local resources are insufficient to cope with what happened. And there is a lot of debate and research around how many mental health problems we actually have in a humanitarian setting, and that's an endless debate. But what I usually use are these estimates by the World Health Organization. We can talk a lot about that, about the validity, about how these data were collected. But this is a relatively conservative estimate. So the data are corrected for the way they were collected. So clinical interviews, score higher, and interviews with social functioning included instead of only counting symptoms through a checklist approach also is weighted stronger. If you do that, you can say that in humanitarian settings, around 1 in 5, that's the 22%, has a mental health issue of significance. So what I mean with that is it's so significant that it's difficult for the person or the environment to cope with it by themselves. So you would like to offer some kind of support. And 1 in 20, that's the top row, the 5.1%, have a severe mental health issue, which could be what we usually call severe mental disorders, psychotic disorders, bipolar disorders, but also here severe depression and severe forms of post-traumatic stress disorder. So that's the magnitude. This is significantly higher than what you would find with the same methodology in non-conflict affected populations. I must say this is not about refugees per se. This is about people living in areas that have been affected by major emergencies or forced displacement in the last decade, which is basically the group of people that I work for, but it's a little bit different from refugees in high income settings. What is important here, also you can see that in these prevalence figures already, is that it's not only trauma, but people often assume when I say what I do, they say, so you're working in trauma therapy. And that's not really the only issue. It's also a lot of issues related to pre-existing severe mental disorders and to non-pathological distress or adaptive distress, as Derek Sylov has coined it. And what is important here is that the relation between potentially traumatic events and individual outcomes are mediated to a large extent by daily stress factors. This is a famous research or review article by Ken Miller and Andy Rasmussen that is kind of classic in our field. Now that leads us then to a kind of model that we use based on this very schematic pyramid of multi-layered intervention services. It dates from 2007, when a kind of international committee of experts developed some conceptual clarity in a field that was emerging, but it was also highly polarized with very strong and contrasting views. And the approach here taken was very much a pragmatic consensus-seeking exercise to see, can we agree on what needs to be done? And what you then get is this: you see interventions in different layers of intensity. From the bottom, particularly social interventions integrated, or social considerations, I say it wrong, integrated in basic humanitarian work, which helps alleviating a lot of distress if you do that well, to the layer 2 above that, which is strengthening what social supportive mechanisms there are within communities. And communities are, of course, often shattered in forced displacement settings or in emergencies. There is a reason why we call that the bottom 2 layers, because that's really the foundation of the other things. Sometimes, however, people are not able to solve issues within their own social environment and they need some additional support, and that's the top 2 layers. And then the difference is the level of specialization, with layer 3, focused support provided by people who are not professionals, or at least not specialists. I say it slightly wrong. Now let me go through it a little bit in detail to unpack it. This first layer, the bottom layer. So that's integrating social and psychological considerations in whatever you do. For example, in shelter, you see here 2 slides, 2 photos from the current emergency in East Sudan, where there is a high number of people from Tigray in Ethiopia coming in. And on the left, you see a camp that's obviously constructed by shelter experts. It looks a bit like a Roman camp in the Asterix and Obelix comics that I read in my youth. And it's probably, and the shelter planners are very proud of it because this is like an efficient planning. You can control all factors. And on the right, you see a camp that was established just 2 months before and actually is largely self-settled.
Look at they already built the first house.
Sorry? Can I continue? Hello, can you still hear me?
I'm not sure where that came from.
Oh, okay, so then I continue. So on the right, you see a self-settled camp where you actually see, if you look, I don't know if you can see it, but where you can actually see the tents are placed by the refugees where they thought it was most appropriate, which is families and communities together having tents in kind of concentric forms with an open space in the middle, etc. So this was, in terms of shelter planning, a horrible camp, but in terms of communal well-being, the preferred one. So that's what this layer means, and there are more examples, and this is getting more and more attention. You see some examples about mindful sheltering, about integration of psychosocial aspects in water and sanitation, in education, etc. So that's the layer, the basic layer, layer one. And layer two is about helping people help themselves. You can do that in many ways. One way is by training people in psychological first aid. You see examples here in this slide. But you can also train people within communities to become helpers. And if I have I will show, can you hear it?
ক্যাম্পর মধ্যে হবে তো না আসন হঠাৎ তো না শোন তেমন যদি হইতো না আরে
এটা সে বর্মাত থাকিতাম বর্মাতি 30 অগস্ট 2017 আমাদের আসছি এটা এখন থাকি দিয়ে 2 বছর 4 মাসেই
ওই কমিউনিটি সাইকোসোশ্যাল ভলান্টিয়ার হামগান করতে অনেকেই কি শিখি পাইছো না তুমি কি মনে হয়
আর আছে কমিউনিটি সাইকোসোশ্যাল ভলান্টিয়ারিং গরমमध्ये बहुत কিছু শিখি কি গেনলে আর দিলের আর আমি তন দিল শরীরে দিলে কান ভালো কথা দিয়ে শিখি আর আরতে আছে হনকান অশান্তি হইলে আর কি করি মানে কি হয় না বুঝি আর দিলের আর আমি তো অশান্তি মানে কেঙ্গলি দাগই কেঙ্গলি শান্তি আনাতা আর পরিবার আমাদের অশান্তি কথা আর কি করি আর আছে এই শিখি যে নাকি ধরো আত্মীয় অশান্তি হইলে আই নামাজ দোয়া করি কোরআন শরীফ পড়ি তো এই গান শুনি
Well, this was a big success, I think. Hello? Hello, here I am again. Could you hear anything of what Jamal said? Okay, I see that my connectivity now, and I don't know exactly why that is. What I will do is I will stop the slideshow to make sure that the video has ended. Voila. And now I'll start it again. And perhaps it's better now. Can you hear me better now? I still hear Tom. I think it's Tom from a very far distance. But
Okay.
you can
I
hear me well?
Yeah, if you can hear me now, we were just having a problem with the video. We can hear your spoken voice quite well.
Perfect. So then I'm sorry that the video didn't work, but I wanted to show it to show you how a person who has actually very limited formal education can fulfill a meaningful role within mental health and psychosocial work. And as you can see, this is a person who has learned a lot to help others, but also has learned a lot about how he could cope with distress himself. So that's that layer 2 of strengthening family and community support. I would now like to go to layer 3. That's actually when you want to have an outsider involved. And that's what we call scalable psychological interventions. And those are basically, how I would say, it's psychotherapies or psychotherapeutic techniques, abridged, adapted, and packaged in a way that it can be used by non-specialists and can be done in resource poor settings, at least poor with formal resources. They're mostly based on cognitive behavioral therapy, and they are also mostly manualized, which means that the content is written down in a kind of almost cookbook model where a facilitator can quite easily follow it. There are several examples of it, and I will not go through all of them, but the most fashionable now these days is Problem Management Plus, based on cognitive behavioral therapy. And to unpack it a bit, it's a 5-session model, individual or group, that aims to teach 4 strategies to deal with distress, which is stress management based on slow breathing, problem-solving techniques, making decisions when you feel overwhelmed by many problems and you don't know where to start anymore, behavioral activation, particularly for people who are depressed or so full with negativity that they don't know how to take steps to become active again, and 4, strengthening psychosocial support mechanisms. So finding people in your environment to connect with and then do that in a stepwise approach. So I wanted to highlight this because these actually are very common sense methodologies that you can imagine have high relevance in many different contexts. There are other examples, and the last one about IAT, I'm pretty sure Derek Sylov, who's the father of it, will talk more about it. Then layer 4 is clinical mental health care, and that means actually you work with medically trained people or clinical psychologists and ensure that in every health center, in every health facility, there are some staff available who know what a depression is, what psychosis is, or what even epilepsy is. And the tool that you see here is I've been heavily invested in. I was one of the main consultants in working with it. We've rolled it out, as is the terminology, in UNHCR, and we've done some external evaluations, and we actually have fairly positive results in the sense that we see that people who are trained in a training of a week are better able to identify people with mental health issues and also have a more positive attitude towards people with mental health issues. So for time, this was my elevator pitch. This is what I usually say in a talk when I want to convince people that mental health and psychosocial support is important and that we can do something. I wrote an article or an editorial about it, a little bit triumphalist perhaps, but I believe in it. But I think I have 5 minutes left and I want to spend the 5 minutes to reflect on what I just said. Because
you have 2 minutes.
2 minutes, then I will do it very briefly. So the critique that comes up in me when I think about what I'm doing is, and I'm going back on these layers, I go to layer 4, the top layer. And when you talk about integration of mental health in primary care, the risk is that we essentialize concepts that are actually not so hard as they are taken. And too often, to my horror, I see simplified metaphors of neurotransmitters being used in primary care, and I think it's too simple. It's too simple. And we also have a tendency to silence alternative ways of looking, alternative ways of looking at severe mental health issues in particular. But then again, even when I go that way, I say maybe we are silencing alternative views. Then I always think about this man to the left. It's not him, but it's someone I met in Afghanistan when I worked there 18 years ago. And he was in a traditional healing facility where a kind of Sufi shrine was buried, a sheikh was buried, and he was locked. And we could somehow liberate him and give him a decent mental health treatment that greatly improved his functioning. So there is a bit an element of, are we imposing Western views with all the shortcomings in populations that actually are not waiting for that? Or to what extent are we actually doing more good than harm? And do we really have something to contribute? Now, I think my time is almost done. I wanted to say something about the layer 3, the scalable psychological therapies, and particularly to what extent they are actually framing distress into psychological jargon. And I was very much influenced by the book of Wakefield and Horwitz about the loss of sadness, about how psychiatry transformed normal sorrow into a mental disorder. And you can see that actually happening to some extent in humanitarian settings if you don't take care. There are some ways to do it in a better way. This, for example, community-based social therapy is a scalable psychological intervention that is actually more social than psychological, even though the effects of it on the people who are in these groups is profoundly healing, also when it comes to psychological aspects. And then I think I need to stop because I wanted to go to layer 2, the strengthening of family and community support. And what I too often see is that communities are used in a top-down approach. So they are utilized to transmit messages and to bring people to the clinic where the real stuff is happening. What we need to do much more is a bottom-up way of working in which people are empowered to do the things that are really important to them. I'll go to my last slide. I'm sorry that I had so little time for my doubts and reflections, but my question is, how can we navigate through, let's say, respectfully using the body of knowledge that we have gathered in global mental health, which is impressive, but not fall into the trap of imposing ways of looking and thereby silencing alternative modes of seeing. And I think the answer is in these 4 bullets that you see. It's working with community members, use qualitative research to complement the quantitative research, of which there is a lot, listen to community feedback and really listen to it, and have a certain professional humility. There's a lot of talk about cultural humility in practice. I think we also need professional humility in the sense that perhaps a professional is not the one who has the answer. Sorry for taking too much of your time, but thank you very much.
Thank you, Peter. I'd like to start the questioning by referring back to the article you showed about conceptions of mental illness in four African countries. It brings to mind Robert Edgerton's famous article from the 1960s about the conceptions of psychosis in 4 African countries. And we've been dealing since at least then with the issues of cultural meanings of mental illness in relationship to professional psychiatry. And I want to ask you a little bit about that, but even more particularly about your sense of the challenge of indigenous healing for global mental health. Indigenous healing, ritual healing, folk healing, religious healing, whatever term we want to use for it.
Thank you for the question. I did a very close reading of the Edgerton article when I did my research in Africa. And I must say, I quite like what he did, although it is, of course, conceptually quite an old-fashioned approach to ethnography, but yeah, there is value in it. The question is, I think, a very, I mean, the proof of the pudding is in the eating, in my view. And what I think is difficult is to what extent traditional healing and ritual healing can help with people who have states of psychosis or mania, for example. There is some evidence, of course, that may work, but I've seen also a lot of the opposite. People being chained, people being abused in traditional healing settings. So I find that a difficult question. It's if you would ask me whether indigenous healing is helpful for people with a depression or with a dissociative disorder, I would absolutely say yes. In many cases, I've seen very good results. When it comes to severe mental disorders, I hesitate, but maybe I should, this needs a longer discussion, obviously, but yeah.
Indeed, thanks. Especially because there's so much variation among different forms of ritual healing. There needs to be renewed effort for detailed ethnographic description at the level of experiential specificity of these different of the nature of therapeutic process in these different forms of healing. Let's turn to Catherine.
Hi, Peter. Can you hear me?
Yes.
Nice to see you. Nice. So you basically make a point about how we understand a body of knowledge without imposing changing practices of care without imposing a mindset at the same time to do so. So engaging with communities collaboratively when you're trying to change the practice of care. But I was very struck when you started the video of Jamal, who was interviewed by, I think it's in Nepali, possibly, by this woman who is, or Nepali similar.
It's in Bangladesh, but it's, yes, it's close. Similar language.
Yeah. So the Bangladeshi woman, who I suppose is a community worker, switches into English with 2 words when she says the word community and when she says the word psychosocial. So so it's an incredibly interesting example on how 2 people are talking about the benefits of psychosocial care, but switch to English to explain the concept of community and the concept of psychosocial. Now, I'm not particularly anxious about it because we need to innovate on concepts, and we have this, bricolage. We take one word from one language and put it in another, but it's striking that she uses those 2 English words. Do you want to tell me, I'm not surprised about the word psychosocial because I think that's a really difficult one to find in the local language, but it did strike me that it was about the word community, because that would be an easy local equivalent. Do you want to comment on that?
Yeah, I can't give you the full answer because I hadn't noticed it in this video, I must be honest. But there is an issue also with the language, because the refugee speaks Rohingya language and the interviewer speaks Bengali, but not of the Chittagonian variant, which is more similar to the Rohingya language. So there are issues with language here, even though they seem to have a conversant dialogue with a similar language, but actually there are differences. And we have tried to assist here by, for example, making vocabularies and having a review based on ethnographic research on local concepts. But the translatability of some key terms of the work that we do is limited.
Mm-hmm.
It's a bit worrying if even a word like community or family would not be translatable, because that can't be true. That just cannot be true. So I don't know what's going on here. Yeah, but your point is well taken.
Thank you very much, Peter.